Well, well, welcome everybody. This is our third installment of Conversations in Health for this fall semester, and we have an extraordinary public servant with us tonight, Ambassador John Nkengasong, who was most recently was the United States Global AIDS Ambassador. Prior to that, was the founding director of the Africa CDC. I think we'll find this an incredibly informative evening. So thank you, John, for joining us. So just as a reminder of our format for everybody, we'll first start with introductions for everybody in the class, and we got a few guests here tonight, so we have a bigger crowd than usual, so we'll quickly go around. And then we'll take the first 20 or 30 minutes or so for us to talk a little bit about your career and how you got to the amazing work that you're doing. We'll talk a little bit about some of the key issues today, and then we're going to turn it over to our students. So 5 of the students in the room here have prepared briefing emails for their colleagues to be ready to ask you tough questions. Okay. So we'll get ready, and then when we're finished with that, we'll open it up to the rest of the class, and then if we have some time, open up to questions for our guests and people online. So, as I told you, we always like to start this off with at the beginning. So, I wonder if you could give us a little picture about where you grew up and how your interest in science and medicine started. I know that you didn't start here in the DMV. So, tell me a little bit about it.
Absolutely, John. Thank you, first of all, for inviting me I'm looking forward to an exciting conversation. The background is very diverse, so that is important, and I hope it will contribute to an enriching conversation. We have been planning for me to be here for months, and I was joking with John. I said I used to work for myself, but as ambassador at PEPFAR, but now I work for somebody, so I take instructions from somebody. So
well, we're happy that you were able to squeeze us in, so thank you.
I was born in Cameroon many years ago. And grew up there to the age of 24. Did my undergraduate at the university in Cameroon, and after I graduated, I didn't know what to do.
Did you study sciences?
Studied sciences, natural sciences. I just not because they were not attractive options. I just couldn't get myself organized enough to think of what is it that I want to do. Okay, I started off with, maybe in graduate I should look at wildlife management, right? And then I thought, that's not good enough. I want entomology. Who knows what entomology is about?
The study entomology, anybody?
Yeah, anybody knows about that? Study of insects, how insects affect plants and whatever, because I thought, if insects are affecting plants and a country like Cameroon is very agricultural, then if I do that, it will be important. I was looking for something that would be important in life. And then I met, at a medical school, I met a professor there, and I said, if you were me, what would you do? And he said, it would be exciting to study virology. And I said, what is that? I've never heard about virology. So, and there were no phones, so Google and find out what virology is about. So I went to the library, search, and it was exciting. It started pointing me to some of the very difficult things in life. At that time, viruses, and still today, causes a lot of death. At that time, hepatitis B was a very bad virus. It's still a dangerous virus today. And the more I read about it, it felt like there was no cure for viruses, right? There were treatment, there was no cure for viruses, okay? And even today, it's no. And something sparked my interest that is what I want to do. I want to be part of finding solutions to this.
So you didn't grow up in a family of scientists?
No. My father was not educated. My mother was not educated. really never been to school.
Were you the first then to go to college?
I was the first to go to college, and
They must have been amazingly proud, but how did they?
somehow my parents knew that going to school was important, but I still don't know that they knew the depth of how important it was. But they were very passionate that I have to go, and they did everything possible to. When Cameroon has a system, it's an Anglo-Saxon system because Cameroon was colonized by the French and the English, right? I grew up in the English part of Cameroon. So you have the primary school and secondary school and high school, which would be elementary school. So my parents they were poor, so they had to sell like a couple of pigs to send me to secondary school, okay, to go to middle school. And so, but that just shows you the value they thought it was for education. They were very interested and keen to get me educated. Yeah.
So when you met this professor who pointed you to virology and it sparked an interest, what did you do then? Because you had just graduated from college, but you didn't have any training.
Absolutely,
in this space.
yeah. I mean, and it sparked that interest, and at times that's where I started the conversation with the background. I like the different backgrounds. At times you work hard, you're intelligent, but your destiny is shaped by events that are out of your hands. So I joined the medical school for an internship, and I just was trying to get something to be busy. And the internship happened to be in the area of screening pregnant women for hepatitis B. Hepatitis B is a virus, right? Dangerous virus. It has a vaccine, but it causes liver cancer if not detected and treated. And at that time in Cameroon, very few people were vaccinated, especially pregnant women. And so we had a small grant from the UK to do a screening of pregnant women. So at midday, out of my curiosity of science, I'm in a lab. And this lab was a two-room toilet that the medical school had given because of lack of space. The medical school had given my supervisor that, and we transformed that into a lab, okay? And so we kind of knocked down, they took out the toilets and remodeled it, and it was a lab. So I'm in there doing my experiments, incubating cereal and conjugate, and I hear a knock on the door. And I turn around and I see somebody there. I always remember it was a pink shirt, a polo shirt, and it was Peter Piot. He knows Peter Piot. He was the founder of the UNAIDS and then became the director of the London School of Tropical Medicine. So I look at that, and then I waved and I said, you should get, because when you're doing your experiment, right, you conjugate your substrate, you have to be really there.
Right,
and
nobody can interfere with
nobody can interfere because you mess up your whole period. And so I did all of that, washed my hands, put that back into the incubator, and then I opened the door and I wanted to know what he was. So he was curious to know where my boss was. And I told him that my boss had traveled to Abidjan. And I don't know when, of course, it was not my duty to know when my boss would come back. I was just doing my work. So he waited, I finished my experiments, and then he took down my name and stuff and went back to the hotel. And 2 days later, he was in Cameroon for an STD conference, sexually transmitted disease conference. And 2 days later, I got a call from the hotel that I should come meet him. And he had taken out scholarship forms from the Belgian embassy and brought it to me, and that I should fill it. And he was very, he was amazed that at noon, at 1 o'clock, I was in the lab doing experiments and my boss was not there. And very typically, where your boss is not around, you are 22 or 23, you doing your own things, and you okay. So I did that. Let me step back. I said, no, my boss is not around, so I cannot fill that form because he has to give me the permission to do that. So I didn't fill the form. My boss came back from Abidjan. I showed him, I explained what had happened. He said, no, fill it, and submitted it. So anyway, fast forward, that's how I got a scholarship and left Cameroon to go to Belgium.
Belgium.
Now
Okay.
to do the virology.
Okay. And so how long were you in Belgium?
I spent about 8 years in Belgium total because I did 2 masters in Belgium at the Institute of Tropical Medicine in virology. Then went to the Brussels, the School of Medicine, and did another master's and did a PhD in virology, HIV virology.
So you were on the path to be a scientist, or maybe a bench scientist. Is that what you were thinking at that point?
At that point, I was interested in knowledge. Just remember HIV. You're doing your master's degree, and there's no textbook
Right,
in HIV,
okay.
right? A textbook was the medical literature, okay, published by the likes of David Ho, Tony Fauci,
Right.
G. Levy. Those were people, I call them virtual mentors because you read their work in the literature, you saw them in conferences, like the AIDS conference in Amsterdam. And I remember I would buy a small, if you recall, John, there used to be these small recorders, right? I mean, like half the size of
Right,
this.
exactly.
And I got one. And when people like Tony Fauci were giving these seminar lectures on the HIV pathogenesis, we were sitting in the front row, very attentive. You're holding it there and you're recording. You go back to your room, you transcribe that to them. That's how you did your PhD at that time because there was no textbook on HIV. The very first textbook that was published in HIV was the HIV pathogenesis by J. Levy.
Okay.
And it was born out of a review that he had written in Medical Microbiology Review, one of the American Society of Medical Clinical American Society of Microbiology journal. So I mean, so you were just you led with curiosity of what is this HIV? What are we? Because suddenly there were subtypes of HIV. Then HIV neutralizing antibodies there. You wanted to be interested to know that. You thought you could be part of a group that can discover the vaccine because we believed that we could discover a vaccine. This was in the mid-'80s.
Mid-'80s, when everyone who had HIV died.
Everybody who had HIV died. And
So
growing up in Antwerp, in Belgium,
Oh, please.
the epicenter of HIV was in DRC, the Burundi, the Rwanda. So we had a relationship born out of colonial days with Belgium, and I mean, so I used to go there in DRC to collect samples to come the project CEDAR that the US CDC had established there. So it was really curiosity of I mean, the problem that you had in front of you was to solve the HIV problem, okay, as part of a network of scientists in the world.
So you finished your graduate studies. You were studying the most a frightening new virus, but you were in the midst of learning in real time.
Yeah.
So what was the next step after Belgium?
The next step, interestingly, is so you studied that. Then I got married.
Okay.
Then Pete was born.
There you go.
Yeah, I mean, and
So we're going to add people as the events of life come.
Exactly. So here you are in a graduate school. You are now a husband and a child, and you spend the whole night up because he's crying the whole night, and then in the morning you have to take your bike to the lab, and you have culture about 50 viruses that you have to culture, that you have to change, right? Culture is you grow the virus, the HIV virus, and in the Petri lab, and I mean you stay in that lab for almost the entire day because you have to feed the viruses, you bring in new cells, so every little thing that you do, after 7 days, it took about 7 days or more to grow those viruses, so you have to be very careful that you don't contaminate, because you can easily, after 7 days, contaminate everything, and you just have to throw it up. So how do you wake up in the morning where you haven't slept because this guy has been crying the whole night, and then you go to the lab and you still pay attention and do your experiments and whatever that, or you sequencing them. I mean, so the technology was very crude at that time. It wasn't now that you could sequence virus within hours. You could do long end sequences. There wasn't. So you first had to culture the virus. You extract the DNA. You sequence it, and so it was just. It was crude, I mean, compared to the speed at which you're doing things today. But it was exciting because
And did you go to when did you get connected to the CDC?
So this is interesting.
So your life so far
Yes.
is in Cameroon
Yes.
and in Belgium.
In Belgium. So
And we haven't even hit the
No,
place that you've worked
absolutely.
the longest.
So I've finished my PhD, and then Peter Piot
Yep.
is leaving Belgium to go to start up the global program on AIDS in Geneva. So WHO, the World Health Organization, decided they would create a special program for AIDS. So he was the head of department, and as he left, I was just 33. And he said, "You publish a lot, you're a good scientist, I want to make you the head of the virology lab." And I said, "Wow, me, this is an African in Belgium,
Right.
and it's all white Belgians, and,
Right.
and they, I mean, in Antwerp, I mean, they're a very conservative part of Belgium." So I remember sitting down with him in Tokyo, at the AIDS conference in Tokyo, in Yokohama, and said, "No, I don't think I can do this job." He said, "You do it, you can do it. Just stay focused with the science." So that's why that's how he made me the head of the lab.
Okay.
At that, I mean, and had about, it was a group of about 20 Belgian researchers, but he said, I mean, and I was 33
Okay.
years old. So I did that for about 2-3 years, but I was longing to go back to Africa. And I said to myself, I've spent close to 8 years here, and I'm really in need to go back to. So I went to the library, and every Monday I did that. And as a staff, I was now a staff. I mean, the journals, the Lancet Journal of Virology, they all came in, and they put them in a little room like this, first for the staff to read. Then after that, the next week, they'll take that to the main library. So I went there every Monday afternoon during my incubation, my experiments, and then read those. So I saw the Lancet, and it was advertised in the Lancet that they needed the virologist at the US CDC lab in Abidjan. So I photocopied that. There were no emails. I photocopied that and wrote my application and faxed it over to. And then I realized that I didn't think that I was senior enough to. Remember, this is 35 years. So I didn't think my application would be considered seriously. So I didn't even discuss it with my wife. But then 1 week later,
that doesn't sound like a good idea.
No. Later, 1 week later, they wrote back to me. They said they're interested in talking to me. Then I went back and I told her, I said, I saw something in the Lancet and I applied, and it looks like he said, "You have a job here. Why are you going back to Abidjan, Côte d'Ivoire?" I said, "No, we spent 8 years here, and I think, let me just go try." So they set up an interview at the airport in Brussels.
Okay.
So these were the US CDC scientists that had flown to Abidjan, and they did work there, because the US CDC had sites, and there were just 3 sites, one in Uganda, one in Abidjan, and then in Thailand. So the researchers in the US, in Atlanta, used to go to Côte d'Ivoire and these sites to support them.
On HIV.
On HIV. So on their way out, they stopped in Brussels so we interviewed. I was interviewed at the airport, and we sat there over a coffee desk, and Mark Rafi asked me a few questions. How many HIV viruses have you sequenced, and what publications and whatever. So there was no way you could find out. Nowadays, you can Google you before your meeting, but I had to explain all of that to him. So that was my interview. Then a week later, Alan Greenberg, who is now at GW, called me and said, "Look, the team is very impressed with you. We need you to come to Abidjan and to see and if you like us and if we like you." So I went to Abidjan. Okay. Arrived Abidjan, and he took me around and showed me a building that they had used for cholera outbreaks in the 50s. And that was the virology lab. And it was a lab that needed to be demolished and then built. So he said, "We'll offer you the job, and I know you see a dilapidated building, but in code," he said, "but I see a virology lab here." Then he turned to me and said, "What do you see?" I And I was like, no, this is not a virus. Remember, I'm running a lab in
exactly. You've seen a real lab.
I've seen a real lab, and I'm publishing, and you really like, it's competition, right? You're publishing in not just the low-end journals, but you're publishing in the high-end journals, and you're like, what is this then? So I said, you should give me a break. I'll go back to Belgium and then think about the contract.
Okay.
So I went back to Belgium and talked to many people, and I remember somebody said, that is an opportunity.
Right.
That's an opportunity for you. You go, you be the pioneer of that, and if you do it well, that lab will address many questions on site, because the epicenter of HIV is in Africa, not in Belgium. So I called back and I said, yes, I need the offer, and they gave me that. I mean, that started a whole new journey. So.
And so you sought that out, and then you spent about the next 20 years in different roles in CDC, both in Africa and in Atlanta. Was it all HIV related?
It was all HIV. So that move, when I heard all of the backgrounds here, something occurred to me that I should say that what you are reading now, where you start your career and where you matured in your career may not have any relationship.
Well, that's a theme I think everybody here has learned. All of our speakers have reminded everybody, it's not a straight line.
It's not a straight line, just straight line. So the Abidjan, I just explained my situation in Abidjan. You arrive, you show you a dilapidated building, but they had advertised that in the Lancet like a virology lab, and you have to now build that lab from scratch. So somehow it became my hallmark that I never ever walked into a job that was there. So I always had to build something.
Okay, you never had a job that you never walked into a job that was ready.
Yeah, that was ready. Yeah. So I'm sure we'll go through this all along, including at PEPFAR. When
I was going to say.
I went to PEPFAR, and then 1 week later, Secretary Blinken turned to me and said, yes, we got you in for PEPFAR, but we need you to build a bureau. So
That's right.
So I created the Bureau of Global Health Security. So I'm happy that the Bureau has survived despite all.
So far.
Yeah, so far. So I think
So you've been a builder everywhere you've gone.
Yeah.
And in all the places, and you went back to Atlanta and built part of the HIV
I
lab
started
there?
the HIV virology branch at Fresh, because when you all started PEPFAR, there was no lab in Atlanta that supported that. So they were borrowing from across different labs at the CDC in Atlanta. So the idea was, with David Burks, was to create a lab and a branch. So I created a whole new branch at the CDC, and when I left, it was the biggest branch. It was the richest branch in terms of, I mean, we had a branch that had about $240 million, and no branch at CDC had that amount. I mean, so
by the time I went to Atlanta, it was the biggest part of.
And it was the only lab that was accredited by international standards, because people thought of the CDC as the know-it-all. No, the CDC, until we created that lab and got it accredited by the College of American Pathology, no lab at the CDC was accredited here.
So you've been a builder all along, and then the opportunity comes to create an Africa CDC.
Yeah.
And my recollection is you didn't have a building or a lab or anything when you started with the Africa CDC.
Absolutely. The Africa CDC.
Tell us how did you, that's not a job you applied for, I don't think.
No, that is, as I said, your career is guided by your passion and your desire to solve problems. And people say, how do you become from a virologist to becoming an ambassador? I say, well, I don't know. I mean, the answer is that you just work, you solve the problem that you have in front of you, and you do it well. So here we are. I've worked at CDC for about 20 years, built a lab, was respected across CDC because, I mean, you built a lab and you're supporting PEPFAR across many countries. And when we started that lab, as the main lab that supported PEPFAR. PEPFAR is the President's Emergency Plan for AIDS Relief, the main HIV program, United States program. When I walked into CDC every day, I thought that was my last day, because I mean, I thought that somehow they will find an issue in one of the countries and that is not working because there was no diagnostic capacity across anywhere in Africa, and you were the main person supposed to support that. So I mean, it became obvious that something would go wrong, but fortunately we worked hard and whatever and we got it. But Ebola hit West Africa in 2014, 2016, and and if you know how frightening those who were following that episode at that time, so Ebola till 2014 was somehow an exotic disease in the Congo or Uganda, and it would show up and not even 100 cases there, but we knew it was deadly, right? I mean, so suddenly
but it would burn out typically.
Exactly, it was small because it was in remote areas. I mean, then suddenly Ebola shows up in capital cities in West Africa, in Monrovia in Liberia, in Conakry in Guinea, and Freetown in Sierra Leone, killed about 11,000 people, and it took like 2-3 years and started being exported. I think cases came to Emory. I mean, like streets were closed in Atlanta because of a case of not a case that was brought in for treatment, right? Not because it happened. So the entire CDC is deployed to support that because the projections were that if we do not do something, it will go. I mean, it can be devastating. President Obama was the president and actually deployed troops in West Africa to help build treatment centers and whatever. So of course we supported that. But as an African, and I look at that and I said, this cannot be possible because Ebola is not difficult to control, right? It's not a respiratory disease where I mean it flows in the air like smoke. I mean you need contact. I mean, which means the very crude methods in HIV surveillance or epidemiology can work. You detect the case, and you isolate the case, and you keep doing that, right? And because there's no treatment for Ebola, I mean, you just isolate that, you treat them with physiological solutions and whatever. So I said to myself, because of lack of capacity in Africa or institutions, African institutions that can support countries to fight this. So I said, well, I've spent more than 20 years at the US CDC, have experience in public health, virology, and then the head of states of Africa said they met in Equatorial Guinea and decided that they wanted to create their own CDC. Secretary Kerry and the chairperson of the African Union, Zuma, met in Washington and signed a memorandum of cooperation requesting the US CDC to support the development of the Africa CDC. The position was advertised, so I applied using my Cameroon passport, and which had expired, and I was hoping that nobody would find out that it had expired. Photocopy and had applied for the. And in May of 2016, they called that I received an email that they had pre-selected me, so I went to Tom Frieden.
Right.
Okay. And at that time,
the head of the
was the head of the CDC. So I remember vividly, Tom was sitting at the head table, and I was sitting right there, and I said to him, I want to go to set up a CDC in Africa. And he looked at me, and he said, this is the position of his hand. He put his hand, he said, is this a mid-age crisis? I was 55. Is this a mid-age crisis? Why would you go to the African Union? African Union doesn't really function the way why would you go there and you have a nice career here? At that time, I was now a deputy center director for the Center for Global Health. Right. Prestigious job, and I said, no, I need to go because I think they need capacity out there, and I can help with it. So he said, well, I'll support you, but it's not up to it's not a CDC job, it's an African Union job. So go compete, and if you succeed, then we can find a way to second you there. So that's so I went, I competed for that. I was shortlisted. Then I came back. They offered me, and the offer was very low. And so I came back to this, and I said to Tom, look, remember we have an MOU between the State Department and the AU, so you can argue that to the AU that I can be seconded through the MOU. So it took 1 year to go to do all of that.
But you got the job.
I got the job.
And you went over.
Yeah.
And what was it like to build a public health organization that reported essentially to a
55
group,
countries.
55 countries,
Yeah.
exactly. So you're like a mini
Yeah.
WHO.
Yeah. So I left Atlanta and on my way to the agreement. The MOU is not yet signed, but we had assumed that it will be signed. So I'm on my way to Addis to take up the job.
Which is where the headquarters
The
of
headquarters
the AU
is.
Okay.
So I'm in Brussels waiting to catch my flight, and Rebecca Martin called me and said, "It doesn't look like that MOU will be signed because they still have problems." I said, "Okay, what is?" But I have to go. I mean, I just have to continue my journey. So I arrived at this. The U.S. ambassador there had already left a note that when I come, I shouldn't go to the African Union. I should come to the embassy because it looks like that MOU is not going to go through, and I might come back to Atlanta. So I show up the next day. She explained every challenge that they are having for the AU side to sign the agreement. And the next day was supposed to be a ribbon cutting of the head of states. Okay, I mean, several head of states were there to do the ribbon cutting there. So the U.S. ambassador says, tomorrow, and my wife, I was there with my wife because it was something big, right? A ribbon cutting, head of states, and so she said to me, this is the U.S. ambassador. Tomorrow at the ceremony, you stand away. This is the new director. Okay, you stand away from the ribbon cutting, and I said, how would that happen? He said, well, and she was there. She came the next day to make sure that I wasn't. She said, if you are too close to it and the MOU is not signed, it will just be messy. So let's try to contain it. We're in a containment mode now of the MOU is not signed, I'm in Addis and whatever. So I stood back. If you look at those pictures there, stood back there with my wife, and everybody is like, where is the director? Come close to the head of state and hold the ribbon. And like the ambassador is at the corner saying, go.
So this is your exposure to diplomacy.
Yeah, exposure. So somehow we grabbed somebody, Maigun, who was the director of social affairs. He grabbed one part of the ribbon cutting, and they cut the ribbon and whatever. So that was my baptism.
Right. In African diplomacy.
Yeah. So you arrive there, and there's no computer. There's no office for you. Yep. There's no staff. I mean, they said, so they showed me a shared office, and the size of the table they gave me was the size tool of your bedpost in a hotel, right? I mean, like that. Was it, and it just was large enough to accommodate my laptop.
So the entire Africa CDC was you
was me.
And a laptop
my
and
laptop,
a corner of a table.
But I was very determined that I would make it work. And then I stayed in a hotel for 6 months while waiting for housing to be arranged. And I didn't have a car. I mean, so for those who have been to Addis Ababa, they had some of the oldest taxis that you can think of. I mean, like Lada, I'm sure these are Russian-made cars that were still. And when you get in there, it goes like that. I mean, and the driver goes underneath, takes some wires, put them together, they connect them, then it starts, and you go in. So those are my things I use every day to go to work at the AU. But it was an opportunity to learn the culture, because it's true that you could really interact with the driver. They told you stories about their life. You learn Amharic, the local language through that. And so it was a kind of missionary attitude that I said, look, I did this by myself. I did this because I wanted to solve a problem, and I want to commit myself to it. I wasn't looking for luxury. Like if I could have asked the American embassy to send me a 4 week. I just wanted to be part of the local culture.
But you met heads of state. You were interacting with
yeah,
leadership.
Exactly. So you started off with a piece of paper and a pen, and you drew an organogram based on the US CDC, and based on your knowledge at the US CDC, this is what an org shall be, and what is possible in 2 years, what is possible in 5 years, and the long term of CDC doing. And what do you need to take to... The African Union is not a rich organization. The entire budget is like 700 million. So you were going to be realistic and start off with a very modest budget. And that modest budget was like 10 million that I requested. They beat it down to 5 million. And I said, okay, that is okay. But I was determined to make it work. And so that was enough to start hiring staff. I mean, you advertise, it takes like a year to create a position description, advertise the position. For every position that was open, about 50 people applied. And the rules is that you have to talk to everybody. So you can imagine that you have to do that and select the right people, and you start that's.
And how big was the Africa CDC when you left?
When 6 years later, I left Africa CDC in May of 2022. So I started in 2026, May of 2022. There were 319 staff.
So from 1 to 319 in your
to
time.
319 in 6 years. And the budget had increased from the 5 million to 1.8 billion because of COVID. COVID came, and the MasterCard Foundation gave, because of the trust they had, gave me 1.5 billion. Then the World Bank gave me 100 million. Then the World Bank, before the 100 million, I've been to the World Bank multiple times to meet with the president, and all I could get was 10 million.
Yeah.
And that was a lot of money for me. And when COVID hit and they heard that the MasterCard Foundation had given me 1.5 billion, they sent a delegation to come to see me and say, well, we can give you 50 million. And I was proud at that time. And I said, who told you that I need 50 million? And if that's all you have, I think we are very busy here responding to COVID. And then a call came from the leadership. They said, how about 100 million? I said, that would work.
Exactly. So you developed your diplomatic skills and your ability to raise money.
Yes.
And then fast forward, President Biden and their team asked you to come back to so you had 6 years, you built something. What made you intrigued to come back to the U.S.?
We built something, and it was perhaps the most challenging job that I've ever done in my life, but the most rewarding, the most stressful during COVID, because you were the face of COVID for the continent, right? Everything that, and it should. I'll come back to President Biden, but this piece is important because it makes the Biden call very important. So the head of states, the way the African continent operates is that every year there's a rotating head of state who is the chair of the African Union. And at that time it was President of South Africa, President Ramaphosa. So the President of South Africa, Ramaphosa, is supported by 5 head of states. They call it the Bureau. It's like his cabinet. Then they are further supported by the 5 presidents that exited the year before, and then the 5 that will be coming in after 1 year. So it's a total of 15. So the 15 of them will come in every month on a Zoom call and put you in the center for 3 hours and say, tell us what are we dealing with now, this COVID thing, what is it, where are we, what are the trends, what are you doing, what do you need from us? Okay. And before that, I've never seen a head of state closely, right? And I've never talked to a head of state. So you start talking to one head of state, but you are interacting with 15 of them every month. Every month, they'll put you at the center and they say, we now need to get from our CDC director, Dr. Nkengasong, to tell us what we're dealing with now and if we should come together for the AU summit. It was the first in 3 years, the AU didn't come together as head of state summit because they were relying on a technocrat to tell them whether they should come to Addis Ababa or not. Okay, that's just important. Yeah.
What an amazing.
So we became very close to the head of states. You could text them, the Kagame, the Uhuru Kenyatas, and other. It was very, because Museveni, they would text you like at night, like call in the morning, and it was just very. The COVID reduced the barriers because it was like, we need this diagnostic now. When are we getting the vaccines? The vaccines have come in. What do you think? So anyway, fast forward.
And they trusted you.
They trusted. That was the trust, because you gave them advice. Like each time they would say, well, can we go to Addis Ababa for a summit? Because each year the president meet for a summit, they'll say, can we come to Addis Ababa? And I'll say, well, I cannot tell you, this is a political decision, but this is what the situation is. If you have to come to Addis Ababa, these are the things that you have to have. Okay, and then they themselves will say that no, we are not coming this year. I say, I'll give you the technical considerations, and you make the political decisions. Okay, and I mean, they always did the right thing by staying away from it. So in the middle of that, vaccines were scarce, but with the team that we built together, Strive Masi is a prominent businessman in London, billionaire, the president of the Afro-Exim Bank based in Cairo, Benedict Orama, had committed $2 billion to me because I've reached out to him and I said, look, we need to solve this problem. We don't have vaccines and we just cannot rely on COVAX. COVAX was a mechanism that was set up in Geneva to distribute vaccines to the developing countries, and it wasn't working. And again, in public policy diplomacy, what you hear on media, take it with a grain of salt, because COVAX has been projected like we have raised $7 billion for vaccine. They didn't have money. So because they didn't have money, they couldn't sign contracts because the US, Canada, and others have all taken the vaccines. So we are now left on our own. So I had to create a small group. Well, not me. President Ramaphosa on a Saturday called us and said, I want you all to go out there and be relentless in finding the vaccines. John, you are the public health person. Orama, you are the president of the bank. You find the money. Strive, you are the businessman. You know how to negotiate. And then Vera Songwe, who was the head of the UNICA, the United Nations office there, you talk to the World Bank and the ministers of finance. That was a small team. So every night from 7 p.m. to 11 p.m. at this time, we'll be on a call. We had our dinners together on Zoom. You eat, we turn off the Zoom and you eat and what. So we secured 400 million doses of vaccines for the continent using the 2 billion that the Afro-Exim Bank had made available. So the vaccines were available. Then the MasterCard Foundation came in with 1.5 billion to allow us the vaccination, because as we developed a slogan that said, vaccines without vaccination is no vaccines. Okay, so you could get the vaccines to the port, but if there were no nurses, so the MasterCard Foundation availed that money. So we were at a point of really solving the problem. Okay, right. And then I came home. So I used to come home like 11 p.m. You leave at 5 in the morning, you come back at 11 p.m. at night. But because COVID was beginning to ease, I came home a little bit early that day. It was 9 p.m. I remember that, and it was only my wife and myself. We sat, had dinner, then kind of sat there, watched TV news, and attend to my phone, and just kind of lazing on the phone, and attend to my Gmail. And I saw a Gmail that ended with Executive Office of the President, EOP. And to me, I thought it was a scam. And I said, and I read it for that. Then my wife said, why are you so reading this? Is there a problem? Why are you so? Then I showed her, I said, this is from the language there. It doesn't look like, because during that period, there was a lot of scamming going on, right? Like on vaccines, like people will fake, like they can give you vaccines from India, China, and whatever. It was whole different politics. So you were very careful with anything that you read. But that email said that the president intends to, is considering you for nomination as the ambassador at large for PEPFAR, and the email ended with EOP. So I showed her, she looked at that and said, maybe. Then there was a name there, I think something Zimmerman, Team Zimmerman was there. So I should reply. Of course, I was not going to reply. And that was the most stressful moment, because remember, every month you sat with 15 head of states to discuss COVID on the continent. You secured vaccines. And we had actually planned a trip to go meet with Prime Minister Modi when India refused to release vaccines, right? And so you were their main person. You were the spokesperson for COVID response, the go-to. And now, how am I going to tell them that President Biden wants me to come back to Washington and then abandon them? So it was almost like a betrayal. I tell you that, I mean, for a week, of course I didn't reply, and I couldn't sleep, because each time I slept, even with an AC, I would sweat so much that, I mean, because of the stress of, I mean, what do you do? How do I tell this president? how do I say no to the U.S. president? Because I was seconded. I was still a federal employee, seconded from the U.S. I mean, so that's.
But you decided.
Yeah, I decided. After 1 week and a half, my wife and I decided to go to Kenya and just quiet time and just think about it and kind of reflected. And we called, I called, there's a lady at the State Department that a common friend
Yeah.
was in charge of COVID vaccines at that time helped me. Just
It wasn't.
Former USAID administrator.
Yeah, I know. It wasn't Samantha. It was
No, not
before
Samantha.
that.
Before Samantha.
If
Anyway,
I think about it, I know.
So we used to be on these calls on vaccines or planning, and I reached out to her, and she knew, and called me. I was in the park in Kenya just because we wanted an environment that was calm to think through and process it. So she called me, and I called her, requested to talk to her. I said, "What should I do?" And she said, "If I were you, I would not know what to tell President Ramaphosa." She scared me. She scared the hell out of me, and said, "But it's a good opportunity because I think it could be something big. I think the U.S. State Department can create something out of this." But all I recall is that the answer wasn't straight. Gearsmith.
Yes.
Gearsmith.
Yes.
Yeah.
So it wasn't clear.
It wasn't clear.
But-
It left me with a lot of fear, actually.
But we thank God you made the decision
Yes.
for the United States.
Yeah.
And so I'm looking a little bit. So here's what I'll ask one more question, but I'm going to ask. We'll then turn it to our students. But Pranathi, I think you'll be the first, if that's the. And this will come up in the Q&A. But you've had this amazing experience on the African continent with working with heads of state in, frankly, the greatest public health crisis since HIV. You've come to the United States, and you are the lead diplomat for the U.S. government, not only on HIV, but as you find out, health security. And I can't help but transition this without asking you to reflect for a second. The world's changed a lot in the last several months with President Trump. How do you, given what you've seen, how do you feel how do you feel about where the country is right now in terms of our commitment to global health? And do you see how do you see us moving forward? Because you've seen this from so many different perspectives. But just any kind of status report before we turn to more specifics.
No, absolutely. I think, first of all, the United States should always be very proud that we are a leader in global health with a very distant second. Okay, we contribute about 30 to 40% of funding in global health a year. If you have a pie chart, you see that. And the 32% or so is what we contribute directly in bilateral programs, and then part of the global fund, which is about 33%, comes from us. So if you add all of that, we go to about 40%, and it's for the right reasons. Okay, look at what we did to fight HIV/AIDS. I always think of each time the problem with fighting diseases is that you get into what you call pandemic memory loss. The problem is so big, you're scared, you're frightened and everything, but then the problem is solved, then you walk away like, okay, yeah, let's move on there. HIV/AIDS in the year 2000 was devastating. Life expectancy in Africa, in some countries like Zimbabwe, had decreased about 25 years. In Botswana, the president said that HIV was going to extinct the whole country, right? And then the GDP in most African countries had decreased by 2.6 percentage points, so it was devastating. So I always think of HIV this way, that if President Bush didn't go up there and say, I'm going to create PEPFAR, it was during the State of the Union address, that I'm going to create PEPFAR and ask 15 billion, which at that time was a lot of money, the trajectory of HIV would never have been where it is, okay, today. I mean, it would have been somewhere. I mean, I don't think, because the problem was huge enough, only the United States could solve it. If the United States didn't throw its weight behind, especially the US CDC, smallpox would never have been eliminated. We live, as humanity, live with smallpox for hundreds of years. It killed millions of people. But because the United States worked closely with Russia, Soviet Union at that time, we were able to eliminate the only disease that we've eliminated in the history of humanity, the only human disease. If the United States didn't show leadership, polio would still be having, polio would still be all over the world, I mean, today, and child mortality there. So we as the United States should always be very proud of that. We should always also say that it is not just doing charity for others, it has helped us, the United States, create jobs, innovations, and many other things that I think the soft diplomacy part of it is the solidarity that it makes, it shows who we are as a people, as a country, that we care through our values, okay, of caring there, because no country in the world could do that, especially for HIV/AIDS. HIV/AIDS had killed about 40 million people over the last 35 years or 40 years, and only we could step in and do that. We should be very proud of that. It helps in our standing in the world, our soft diplomacy, and so I say that as someone from the State Department, what diplomacy looks like. Why are we in diplomacy at all? So and I said this in science, the decision we took to just abruptly suspend, disrupt, and cut the funding there hurts us, our soft diplomacy. It hurts us a lot. We didn't need to do that, because we had established a pathway for sustainability to 2030. That was my main thing that I worked for the 3 years I was there, was to say, this is a pathway. And I was talking to all head of states. I went back to the African Union, given my background and relationship there. In February 2023, I met with 30 of them. And I said to them, in 2001, you issue a call for action. We, the United States, came in. We need to now have a conversation with you and dialogue on how do we bring HIV/AIDS to an end by 2030, which is 5 years. And they said, what do you need? I said, I need you to have a declaration, a commitment. They issue a declaration of commitment. You can Google and you find out that. And individually, before I left government, I had met with 12 head of states. The last one was the president of Botswana. Mm-hmm. I met with him, and I said to him, look, we are not here to tell you that we are stopping today, but we need to have a roadmap of how we bring this to an end. And he said to me, in quote, Ambassador, we know what friends do for friends when the friends are in need. We know that friends are not there always forever, and we're forever grateful that you came in there. So the point I'm making, John, is that there's no African head of state that I met with whom didn't think that it was time to think of a roadmap to bring this down to something that. But
that's not what we did.
Exactly. But just dropping the ball there created issues of the whole concept of public health is trust. Okay, if people distrust you, no matter what you bring, let's say public health doesn't work. That is the problem that I hope we'll get into that, some of the challenges that we have in public health. So I think that distrust and what I call the trust capital will take a long time to build that trust capital with the United States and the countries that we work in public health and in global health, because the CDC is not trustworthy anymore. Our funding is not trust. People don't trust it anymore. I say it because I've been traveling around Africa a lot and other places there.
Well, I think that you've hit, that's a perfect transition to, so Pranathi, so we'll open it up to you want to start us off?
Thank you so much. That was an amazing discussion. I was going to talk about the loss of trust, but I guess I'll ask a different question because you sort of touched on it. But towards the end, you were emphasizing how U.S. leadership has historically acted as a North Star in global health and how it's done so much from smallpox to polio to HIV now. I read your Science article interview, and I was wondering if U.S. funding and leadership are continuing to waver as we're seeing with this current administration. What practical steps do you think partner countries and global institutions should take to prevent a leadership vacuum from
Absolutely.
completely undermining HIV progress?
I think I'm very pleased to say that I've seen countries, especially in Africa, show that kind of leadership. On August the 5th, the president of Ghana, and you can Google and see this, called a meeting with other head of states where the meeting was called African Health Sovereignty, reimagining global health governance. Okay, and the thinking was that it was time to, it was thought leadership, right? Thought leadership. I mean, you don't need money to be a thought leader. And I would just segue to say that, and John knows this, that when the Global Fund was created in 2002,
Yep.
it was a thought leadership. It was the President Obasanjo, the President of Nigeria at that time, Kofi Annan.
Kofi Annan was-
I mean, all came together and said, look, HIV is killing people the world, and let's have a global fund, and created that. And Kofi Annan reached out and signed a first check out of his pocket, $100,000. And then that led to President Bush again, with Colin Powell at the White House allocating $200 million. And today is $60 billion. And I saved almost more than 70 million lives. So it's always about thought leadership. So I go back to Ghana to say that I'm very encouraged with the thought leadership that I'm seeing. The president of Ghana summoned that meeting. We were all there. Mark Daibo was there as well, and stuff. And then
Another Georgetown colleague.
yeah, and then he furthered that thought leadership at the UN General Assembly on the 23rd of September. They call it the Accra Reset. Accra Reset. You can also Google that. I mean, and there were 652,000 people that logged into that session just to listen to the President of Ghana, President Obasanjo, and others, to Gordon Brown, the former Prime Minister, I mean, where they're putting their heads together on where do we go from here. Okay, global health is at a crossroads. The gains, and I've mentioned some of the gains, but those gains are fragile now because of this. Where do we go from there? So he asked the question, the fundamental question that the reset asks is that for 80 years we have been governed in global health the way we have been governed. But the custodian of the way we have been governed in global health have pulled the rug under us. Okay, the U.S. is clearly a leader. I mean, the whole multilateralism structure was set up and supported by and led by the U.S. I mean, if the U.S. is withdrawing from WHO, withdrawing from other, or reducing their funding there, then the world cannot just stand idle. So they are now thinking about what do we do. Okay, so that thought process is going on. And lastly, I'll say that countries, especially in Africa are not, and Asia, are not as poor as they were in 2000. I'll consider 2000 as the popularization of global health. Global health has always been there, but because of these two events that happened, PEPFAR and Global Fund, global health took off, right? But the GDP of a country like Cote d'Ivoire in 2000 was like 16 billion. And today, the GDP of that country is 91 billion. The GDP of Ghana in that same period was 5 billion, and today is about 88 billion, right? And you can go on and on. Nigeria was like 100 billion, today it's now 245 billion. So countries can do stuff for them. Just Ghana, the president himself of Ghana said, because USAID stopped funding, I'm quoting him, I went to my insurance money and pulled out 200 million to allocate to the gaps that USAID had pulled out. So the countries can do it. Okay. Now, the health sovereignty is what countries are saying we want, which is I determine what my priorities will be, and if your partnership is so important and solidarity, but it should be aligned with the priorities of that country. Okay, and so that it can be sustained. Again, I'll say this, I said that earlier, the United States should always be proud of the investments that they put in AIDS. Doing that and over time for about 22 years, and I hope it will continue for a little while, but in future, we should always be, what do the countries need? So that our investments are lying in there, and they are driven and they are sustained there.
Guni, please.
So I was able to take a class in undergrad about HIV and AIDS, and we had learned about like treatment and virology, epidemiology. But one of the main themes that we had talked about was the global coalition kind of to end the HIV epidemic by 2030. In your opinion, what are the best like interventions do you think that can help us progress towards that goal?
So there is a very good question. HIV, if HIV, we've lived with HIV for 40 years, and if it was straightforward, if I could stand here and sit here and just tell you the best intervention, then I'm not honest with you, because it would have been solved, right? I mean, it's just, the question when I led PEPFAR was always, what are the tools that we have, and how can we best use the tools in a combination format? For example, we have a long-acting drugs now, like lenacapavir. It's an injectable that you inject twice a year, right? It's not a vaccine, but it's an injectable for HIV-negative people. So imagine if we combine our efforts and say, for the high-risk population or vulnerable groups in Africa, we are going to provide lenacapavir, which is just twice a year. Okay, you inject someone in January, you do the injection in July, and then you come next January, you do that. So that decreases your tap, the flow, right? The analogy I use in HIV prevention is that we have to close the leaking tap so that you can mop the floor. Mopping the floor is treating people who are infected already, okay? But if your kitchen sink is leaking all the time, and no matter how much you mop the floor, you still have water on the floor, isn't it? So the water on the floor is your new infections. So I was always very concerned with new infections, which is happening more around vulnerable populations, like, or key populations, right? Key pops, young people, especially in Africa, and so. But with that, then, long-acting PrEP, and there are other molecules that are coming, and there's a chance that in the next 1 year or 2 years, that molecule can actually be administered once a year. So it almost becomes like a vaccine. So imagine if we are turning up the tap of new infections by immunizing or injecting that in key populations and vulnerable populations like commercial sex workers and others. And then we are intensifying the treatment, finding and treating those who have already been infected. It could be very effective, okay? Because treatment alone has taken us this far, but we know that treatment alone cannot break the backbone of HIV/AIDS. So it will be a combination of both prevention and treatment, and for the long run. Of course, with primary infection, I think one thing we did, which I think I must confess we didn't do right, was to abandon primary prevention, and which is really like teaching young people, I mean, at very early age about HIV prevention and strategies and whatever, and rely more on treatment. Okay, we shifted very quickly to treatment. We just treat people, and then it will decrease their viral load. If the viral load is decreased, they will not transmit the virus. But primary prevention is still important.
Let's see, I've got Ashley.
Yeah, thank you so much for sharing your story and for your time today. I had another question concerning HIV, specifically the development of a new vaccine. Is there good progress being made in that area? Do you think it is possible to have a vaccine by 2030 or?
Yeah, if I knew that that was possible.
We've been dreaming.
I would. Yeah, that would be. I mean, no, 2030 absolutely not, because if there was a prospect that you have an HIV by 2030, I think we would have a hallmark for that, or a marker for that, is that we probably should have about 3 or 4 candidate vaccines going through phase 3 trial. Phase 3 trial is where you take a vaccine into a large population and look for efficiency of the efficacy of the vaccine. I mean, that I don't think we have that. I mean, that is just, I mean, so if you don't have that now, then because you do that trial for about 2 or 3 years, you break the code and the vaccine is there. And even when the vaccine succeeds, you now have to think of how do you roll that out into, I mean, so then we are far from that. I don't even know that we have 2 candidates promising vaccine in phase 3 trials yet. So, but we don't give up on hope. I mean, you just have to. My worry is that what is happening with NIH, because NIH is always that the breeding ground for good ideas, funding of research. If the funding for NIH is where it is now, then my worry is that, and the administration's attitude towards HIV research, then I really worry that having an effective vaccine will be problematic. So,
Daniel, I think I can see you back there. There you go.
So one way to nurture healthcare autonomy in developing countries is enabling them to develop their own vaccines and medicines. And I know that you helped establish the African Society for Laboratory Medicine a decade or so ago. And I also know that there are several African pharmaceutical companies on the rise. So my question for you is what has been the investment on that and what's the return on investment?
no, wonderful. I think during the COVID crisis, that if you recall earlier, I said COVID reduced some political barriers, so you could easily talk to head of states, and they trusted me. And so I had the opportunity to take 3 head of states to Marburg in Germany, right? And I met with Uger, is the guy who developed from BioNTech, who developed the Pfizer vaccine in Germany. Worked with Pfizer, but the main scientist is in Germany. So we spent a whole day there. It was the president of Rwanda, President Kagame, president of Ghana at that time was Nana Kofi-Addo, and then the president of Senegal.
Okay.
So we spent a whole day there looking at that and what is possible. And fast forward, Senegal is now producing. They launched the production of vaccines in a container. So they produce this whole container in Germany and ship that to Rwanda, and the mRNA vaccines, and they are not doing that not just for COVID, but for a variety of things in Rwanda. Senegal has a whole setup that they produce. They call it Madiba. They're producing the vaccines. They used to be the only site on the continent that produced yellow fever vaccines, but now they are working on a whole series of vaccines there. So when I was at the Africa CDC, I set a goal for the continent. I said by the year 2040, 60% of vaccines should be produced in Africa. So again, I'm happy that I continue to see that in the media that they are pursuing that goal as much as possible. But it should be done in a coordinated way, because vaccines are not drugs, right? Vaccines are public goods, where you really have to have a coordinated approach. So in other words, you don't produce a vaccine and put that in a shelf for people to go buy. I mean, it has to be like what Gavi does. I mean, you produce the vaccines. So my encouragement to the continent is that organize yourselves more. Like the West African countries is a sub-region of over 400 million. If you can have a pool procurement mechanism there, and Southern Africa and other, then one or two countries can produce, and it should really be a coordinated effort, okay? The vaccine itself, which is the liquid that you and I get when we go to the pharmacy, is just one. Which country can produce lipids, okay? And which country can produce glass, just glass, the vials that they put the vaccines in, and etc. That if they can work as a network of countries doing that, then you de-risk the fact that if there's an emergency, then one country produces it. I mean, like India, with President Ramaphosa, we were about to go to India and meet with Prime Minister Modi, but he turned that down. He said it was in May of 2021. He said, "Oh, we are so busy. Can your visit be moved to July?" That was just another way to say, exactly, thanks, not thanks. I mean, so the point is that if you do not do that, even if, say, Ghana or South Africa produce all the vaccines, and then we are hit with a security threat, they would like to take care of their people first. Okay, so you have to de-risk that, so that I mean, each country does something a little bit different. But I mean, the analogy of this is the Airbus. The Airbus is produced in Toulouse. We all know it's produced in Toulouse, but the parts come from so many parts of the world and almost across Europe. the engines are from the UK and whatever, the assembly itself is in Toulouse. So, I mean, that's the way I see health security of vaccines for health security should be decentralized and de-risked as much as possible.
Absolutely. De-risking is critical. Isabella?
So what are some key lessons that you've learned having to balance and manage virology and how vaccines are processed with the diplomatic realities and political realities that are happening when we're trying to address the global health challenge with the HIV virus?
Yeah. So your virology training becomes the core of who you are. Okay, it's like the pillar of your I mean, then you flesh that up with management skills, leadership skills, policy skills, and then diplomacy comes in there, right? Because as you grow in your career, some of you will be privileged to take management courses, and I say that if you can do that offline, do it. Because, I mean, invariably, because you're all smart, you will be, you do good in what you are doing and do well, and then they will entrust you on a small group of people. Okay, it could be 5 or 10 people, but the challenges are just the same as if you multiply that by 10. It's about people, I mean, dealing with people, and I think I take a special interest in management and leadership. So, as a virologist, what do you do? And John will agree, you are very focused on publishing your papers, and you're doing well. I'd say at the CDC, then they say, well, I think you need to be a branch chief. They give you 40 people to manage your headaches start, okay? Yes, you go home or in your community, they say, oh yeah, you're a branch chief, you're doing well, but your headaches are just in management. And you are lousy at it because you've never been trained to be a manager, okay? And you're figuring out how to do it. I mean, I was lucky that David Beggs was kind enough to say, go to Harvard and do a leadership and management course, and I went there and did that, and that helped me a lot because everything, when you leave the bench into management, it looks like strange to you. So what is this? Why can't you just know that this is not right and whatever? So, but
people don't behave like
people
cultures.
don't behave exactly. So why can't they? So no, I mean, it's why can't that other institution just be like us? Okay, whatever. But when you start, then you go to policy level. Okay, where there are so many considerations, you're balancing them. Then you move to diplomacy, where it's about. I used to represent the United States in the Global Fund. I was the United States representative at the Global Fund. I was the US representative at the Pandemic Fund. And there you're dealing with the civil society, the other countries that are donating. Even if they are donating a fraction of what you're donating, they are still a seat at the table. So you have to balance what you're saying. It's all about, then you caucus, okay, like the Europeans. I mean, so you have 3 meetings in one meeting. A meeting before, when we go to Geneva for the Global Fund Board meeting, you arrive like a day or 2 earlier, and you find constituencies that you want to sample their mode. What are they thinking about the issue that will be discussed? And then how can I influence them? So that the key of diplomacy is that I make my position your position. Mm-hmm. That's all. When you hear the negotiations are happening in Egypt between Israel and Hamas, everybody is trying to make sure that their position becomes your position, okay? And it might go all kinds of, but that is the ultimate. I mean, so we go to Geneva, you first of all meet with the African constituency, the civil society, and what are you thinking? This is the topic, you get that, you debate. That is the meeting number 1. Meeting number 2 is the meeting itself, okay? And the meeting itself is, in diplomacy, the topic you are discussing is not the topic you are discussing, the topic is outside the room. Okay, it could be that you never be able to say this is why we are not agreeing. Okay, it could be that you can spend 2 days discussing that, but until you know what the issue is, you don't go. Then after the meeting, okay. So there are 3 meetings that would characterize one meeting. So after the meeting, the different constituencies that met before the meeting would say, how did it go? How did it go? Did you think that we achieved whatever? So I think that is just, so your virology skills allow you to be that technician, so you know the issues that are being discussed. Mm-hmm. But then the other skills come in, like understanding and respecting that Vietnam, Kenya, and around the table has the same voice. Humbling yourself in those discussions that even though I'm United States, I have I bring the largest country, but you alone would not succeed, right? Because you need everybody else to bring their little pieces so that you can succeed together. that you cannot bully them to make your position. Your position is all about negotiation. What do I give? What do I take? And whatever. Knowing where your core issue is. We call it at the state, where is your red line? Okay, you have your red line, but the people in the room don't know your red line. Your red line is, no, we are not going to cross that. You start far, and you start negotiating, and you get to where you have to have your win. That's why at the end, everybody always declares victory. Okay, we came in good, because you gave in a little bit of.
So, we probably don't have as much time as for everybody to have a question, but I did start on this side last week, so maybe on this side, are there interests people have? All right, so I'm going to just say we have more questions than we have. So how about, I'll just take a couple. Maybe we'll group them together. So why don't you?
Okay, perfect. Thank you for coming. But I was just wondering, so given the emergence of AI in like every field and especially healthcare, what are your thoughts on how this could be used for the future of virology? Because like I recently read a study that said that AI is beginning to be used to create cultures like technology, like on technology, and they also have been used to modify viruses in specific ways. So what do you think this could affect like the future, and would it be positive or negative? Because people are also able to create any pathogen they want and modify it any way they want as well.
So we got an AI, and who else? We're gonna, let's look with folks in class, if that's okay. Anybody else? Ella?
Yeah, mine, I guess, is a little bit different, more about just the public health responses. I was just going to ask, though, taken from what you've seen in your time at the African CDC and living in different places in Africa, I wanted to ask what you think are some areas that America could take from Africa's approach to pandemic response, and what are some areas that Africa could take from America's approach to pandemic response?
So we got a couple. One more. How about that? Please.
I was just very curious. So you talked about how you built most of the jobs you entered. I just wanted to know if you can speak more to the mindset that you had that gave you the confidence to take on those positions.
So those are three good ones. So AI, a little bit about what we can learn from the world, and then how did you have the gumption to do all those
absolutely.
things?
AI, I'll simply say that we are in a journey. We are in a journey. I mean, good stuff will come with AI, challenging stuff will come with AI. In period, I think yesterday or 2 days ago, I was watching ABC News, and they were showing how they can take John and modify it, and they really show you doing some whatever. You know what I mean? And in pandemic, the most challenging part of fighting a disease is an unknown disease is that it starts with fear, right? If you and I leave this room and you hear that there's some people have some respiratory things around Georgetown, and the key question is fear. Can that happen to me? Can that happen to my family and my community and my country, etc.? How can I protect myself and whatever? So misinformation comes in, and if it's designed that way, I mean, imagine if I was the chief responder or leader of the COVID response in Africa. If somebody would take my voice and myself and then put me out there in the media and say that, and I said things that were not me, I mean, that becomes very difficult to even retract, because everybody is afraid of what is, and they are looking for that leader. I call it somebody who has a folder, and which I used to do press conferences on every Thursday, and I would show up in the media room at the AU, and I open my folder, and I'm reading from it, and the media from the CNN, BBC, the whole world was there, and they thought that I knew something that they didn't know, and they were expecting new news. And most of the time there was no new news. But I mean, you brought in your honesty. I don't have. But imagine if somebody was sitting there, they've created somebody like me sitting there and telling fake news to whatever. It becomes very difficult to fight that. So I think AI, both in the areas of invention, discovery, and others, will offer a tremendous opportunity, but also tremendous challenges there. I just read a report today or yesterday about Deloitte having to return about $400 million for a report that they are reaching out of AI, and it was not even whatever. So
there's a risk.
Let's erase that. So I think that is that America learning from America and America learning from the world. That's the way. That's the whole concept of global health. Okay, global health is not new. Okay, it became very popular in the 2000s, but global health evolved from international health. International health was characterized by rich countries who go to the developing countries like Cameroon, Uganda, Kenya, and help them solve their problem. So it was not necessarily problems that were here. Okay, there's a cholera outbreak, they will go help them. But international health itself evolved from tropical medicine, okay, which was at some point called colonial medicine, which was designed to protect the colonizers, okay? So if you were in Belgian Congo or the French were in Cameroon, the British were somewhere in Africa, the concept was that they wanted to develop that so that it could protect the explorers or the colonizers. Right. That's why the tropical institutes in this world are all located along the seashores or river banks, right? The London School of Tropical Medicine and Hygiene, right there, and the Liverpool, okay, the Antwerp, the school attended in Antwerp and Amsterdam, they were all designed to meet the colonial needs, okay, whatever. So it's a learning, I mean, whatever, however you see it. The CDCs, the concept of CDCs of the world, right? So that's my greatest regret is that we, the United States, you do a lot of good stuff, then suddenly you just throw it out of the window. Like the CDC, the concept of a CDC. We helped build China CDC with John Kopler. Okay, right. We used to go to China to help set up their HIV labs and whatever. The European CDC was inspired in 2003 from us. The Africa CDC, the Korean CDC, and the CDCs of the world, they look at us and like, oh my God, they figured this out 80 years ago and it's working for them. We want it. Then suddenly we are now shooting the CDC. I mean, CDC is shot, but poor CDC has nothing to do with you, right. To the extent that we used to drive in there with pride, with logos. I mean, the tag on our cars, and people will see us at the shopping lots, at the Walmart, and so, are you a CDC? Oh, you're doing such a good work. Now we're hiding, okay, we're hiding, and you take off those logos, you're hiding because, I mean, if you figure out you're a CDC, you are cooked. And how did we get there? I mean, how do we now turn to the world and tell them that any concept or construct that we are promoting, they should follow, because we will sooner or later.
It hurts us here and abroad.
It hurts us everywhere. So I think the learning from the US is the collectivity, right? I think Africa, I'm not saying this because I was at the lead of that Africa is 55 countries, they work all together. Okay, that togetherness, collectivity is what epitomizes global health. Okay, global health is about addressing inequities, and you can't do that all by yourself. The last question about the mindset is just, at times it's just like, you're stupid. You know, and you, I mean, a colleague there said, I set up the African Society for Lab Medicine, and it's true. I mean, and so this is a story, a fascinating story, 1 minute story.
No, please.
So Eric Goosby is the PEPFAR coordinator, okay, the position that I heard before stepping down, and he's talking about country ownership. So I go to Eric Goosby and I say, Eric, all the partners that we have in lab, the U.S. partners, American Society for Lab Medicine and APHL, the American Public Health Lab, and etc. They're all American. Said, if you give me $6 million, I'll set up a society in Africa that can do similar work to them. So he looked at me and said, okay, good, I'll give you $4 million. You go do that. So now I don't know what to do with $4 million. And at that time, right, or 2011. Okay, so Tedros, the director of the WHO now, is the Minister of Health of Ethiopia. Okay. I'm a branch chief at the US CDC. But because I have the connections in Africa with ministers, I invited them. And a branch chief was not supposed to do that, right? I mean, a branch chief, you are very genial. Because the way you engage with our partner countries is that I should have gone to Tom Frieden, the director of the US CDC, then he goes to the State Department, then the State Department engage with those countries. But because I thought I had I'm from Africa, I had a relationship, I invited all of them. I said, we have to meet on the 27th of March in Addis Ababa and launch ASLM. And they all trusted me, and they all came. And Eric Goosby came, David Bex came, and Kevin DeCoe. So I was a branch chief reporting to David Berg. David Berg reported to Kevin DeCock, and then Eric Gusby and 10 ministers. We are all there.
And they all came to your meeting.
They all came to my meeting, and I'm a branch chief. So that's your evaluation right there. If that thing doesn't work, you are done, because you're inviting all of these people. So I'm sitting there, very engaged, and it was one of the best things that happened. Tedros came on time because the meeting started failing because the minister comes like late in the afternoon. So I was calling the Sianesh, who was his deputy. I said, look, make sure Tedros. So around 8:30, I saw Tedros walking into the Hilton. I was like, yes, this thing is going to work. But fast forward, it was successfully launched at around 2 p.m. I went back to my room and I said, my God, what did you do? If this thing, so I caught fear, and I remember lying in my bed with my coat on, my shoes on, and just slept till the morning, because I was like afraid at that time. I said, my God, then my mind started working back. We're like, oh, maybe I'll get a query at CDC that I invited these ministers. So the point of it is that you go with I was trying to solve a problem, and I knew that the only way to do that was to apply yourself to it and make it. So there's what you call in management and leadership mistakes that you do, and they are not mistakes that you did to benefit you, but you're trying to do the job. You do. It's the same passion with Africa CDC. You are sitting there, and you don't have anything, but you're like, I'm determined to get it done, even under a tree, and that's what you just have to do what you have to do.
Yeah. I think I've got time for one more, and I'll go to. All right, I'll give you. You've jumped the gun, so I'll start on the right-hand side next week. So I'm sorry, but go ahead.
Yeah. So one of the difficulties I can imagine of running Africa's COVID response was reaching populations in conflict zones. So how did you and the Africa CDC account for these realities in your outreach and planning, and how can health diplomacy operate in such setting?
Oh, fantastic question. I think the core of health diplomacy is what I call 4 C's. You have to be able to coordinate, collaborate, cooperate, and communicate. So in other words, if you cannot collaborate, you cannot cooperate. But you can cooperate without necessarily collaborating. In other words, I just said to John, well, in this conflict region, that we're going to vaccinate. You don't need to like COVID, but just cooperate. During that period,
Right.
Put your gun down and we can vaccinate. Okay, you are cooperating, but you are not necessarily collaborating with me, right? I think, but if you collaborate, you can cooperate very well. So I think and then communication. It has to be effective communication in those areas where the people really understand what is it there, because the basis for misinformation and everything is communication. Either you communicate inadequately, or you over communicate and people just don't get it. So I think, and the communities. The communities that I think in Ebola. I've been fortunate or privileged to put my hands on every outbreak, every dangerous outbreak like Ebola in DRC Congo. I think we go to the equator and stay there for a week in the remote areas, and it was very difficult to try to vaccinate people in the remote areas. So you show up. I think I have the formula, right? I said we just came from West Africa in Guinea, and we had vaccinators in Guinea. Okay, this is a conflict region, what I'm describing in Congo. So there's a war going on in Kivu. So you show up there. I will come from Addis Ababa, hire a plane from Kinshasa and get into that. Then the ambassador in Kinshasa will be worried. I'm like, wait, we heard John came and then went into those planes were very doubtful in terms of maintenance. But you had to go to the theater of response. But when you get there, there's fighting going on. I'm probably sure you heard about WHO staff were killed and whatever. So you have to build trust with the community. So we are in there for 2 days. We have not vaccinated. Then Professor Moembe came to me and said, "Have you greeted the community?" I said, "What do you mean by greet the community?" He said, "Sit down, ask about their families, tell them about your family, build a relationship." And guess what? Once you did that, the Ebola victims were just at the back compound, but nobody. The first time you came, do you have Ebola victims here? No, we don't have anybody here. But they were down right in the room there with fever. Okay, whatever. So, but once you build that relationship with them, I mean, then even in a war zone like COVID, North Kivu, you could vaccinate that. So I think it's building the trust with the community and really being patient. You build that block by block. Start with the village chief. The village chief now becomes the person who calls everybody else, introduce you, they grab you, they call you their son or their daughter, and then you start. I mean, so it's complex, but you must always think of the 4 C's. I mean, the cooperation, coordination, collaboration, and your communication.
I'm confident that we could do this for a couple more hours, but we won't. I'd like to first ask everybody to join me in a round of applause for our